Good afternoon. I'm Guy Haywood. I'm working with Malcolm in Plymouth. I'm a cardiac electrophysiologist, so a couple of us have strayed into your domain. I think it's extremely important that we take a look at just how sizable this problem is. We're talking about pretty small numbers being dealt with by cardiac surgery approaches at the moment, but this is a massive problem that's facing us, and I think we need partnership. So if you look at the data that's been collected epidemiologically, 1 to 1.5% of the world population is affected by atrial fibrillation. 1 in 4 of us who get to the age of over 40 are going to develop AF at some point. And if you look at the demographics in the European and North American spheres, there's going to be a doubling of the numbers of people affected over the next period of time up to 2050. We look at the worldwide prevalence, we're talking about 33.5 million to 71 million, depending on which estimates you look at, of people being affected, with 5 million new cases every year. This is a huge world issue, and deaths happen to be highest in Western Europe and Australia. It causes stroke, as we all know, 20 to 30% probably of all strokes, and they're the worst strokes because they tend to be the larger clots rather than those small ones that are formed in situ in the veins, and there's a much higher risk if you are an individual with atrial fibrillation to an individual without. And if we look at mortality across the age groups, not just in the elderly, there is an increase in mortality, a rough doubling if you have atrial fibrillation compared to if you're a person without atrial fibrillation. We know that it's highly symptomatic and impacts on people's lives an awful lot. And when you look at surveys of around 700 people, it's surprising how very few, 11.4%, come up as actually having no symptoms. I think we think of the elderly patient who happens to be spotted by chance with atrial fibrillation, but actually when you do the surveys and you ask people the questions, it's really relatively few who aren't symptomatically affected. Probably half of them end up being drug-resistant symptoms. And then if we look at the sort of numbers in the UK, if we talk about catheter ablation, we're coming up roughly in the middle of the Western European family of ablaters. We're doing around 100 ablations per million population per annum. And in 2013, the last national audit, there was 6,443 catheter ablations done in the UK. As we've just been hearing, it's probably, well, maybe less even than 100 lone AF surgical ablations that are being done really up to now, and probably even less in 2013. And if we look at the number of people with it per million, we're talking 10,000 per million, and probably somewhere around about 2,000 to 3,000 of those are people who are drug-resistant, symptomatic, and likely to be benefited by ablation if we were able to supply it. Now, if you look at the breakdown of the types of atrial fibrillation, I'm going to talk a little bit more about this. In this particular survey, some of it was unclassified, so we don't know what sort it was. A lot of it was paroxysmal, but the persistent, the longer standing, and the more difficult to treat patients compose a significant proportion of that. And so a bit of a back of the fag packet calculation says that we're probably looking at around 75,000 people in the UK who might very well be particularly well targeted by the sort of surgical techniques and hybrid techniques that we're talking about here. So a pretty big challenge to us to maybe think of collaborating. If you look at the costs, this is US costs. Because of the greater number of hospitalizations, greater development of heart failure, strokes, they're looking at an annual bill of around 26 billion to manage health care for atrial fibrillation patients, and that's from the American Heart Association. So that's just to set the scene, really, of the size of the problem that we're trying to address. How does catheter ablation for atrial fibrillation work? Now, I realise some of you will have been in and out of your EP's cath lab, so I apologise to you, but I'm trying to just spell out the basics of it. We've had some reference to this earlier today. This was the crucial paper from Michel Hasseguer in Bordeaux in 1998 that put forward this idea that there's basically a starter motor which is located in the pulmonary veins. These little rogue nests of cells that are in the tongues of muscle that extend into the pulmonary veins, that go rogue, fire off a series of fast electrical impulses which exit out into the atrium and then start the process of atrial fibrillation within the atria. And as we know, these are sustained by various rotors and re-entrant circuits within the atrium. So when we're trying to address this by catheter ablation, we will be passing the catheters up through the femoral vein, sometimes using the internal jugular or subclavian veins. The first task is to cross into the left atrium, which is done with transeptal puncture. And when we've made an aperture to cross into the left atrium, we're then passing two sheaths up into the left atrial chamber. One of them carries a mapping electrode, which allows us to build up the electrical picture of what's happening in there. And one is a deflectable sheath, which allows us to guide the tip of the ablation catheter onto the points we want to ablate. And at the end of it, in the more complex cases, we will normally go into the right atrium and ablate the carbo-tricuspid isthmus between the tricuspid valve and IVC in order to block the occurrence of right atrial flutter. So with the mapping catheter, this is one of the forms of mapping that we can use. We are collecting each of those little green points is one of these pieces of information. It's measuring the size of the electrical signal at that point. It's measuring the relationship of the timing of that signal to the other signals, and we're building up a 3D GPS image of the chamber inside the left atrium with the pulmonary veins emerging from it. And we're then aiming to isolate those in much the same way we've been talking about with all the lesion sets today. And this is a sort of we're a small volume centre really compared to many of the UK centres, just 2 cardiac electrophysiologists, but you certainly need a team that's dedicated to doing this on a regular basis, and plenty of capital investment, particularly on things like the mapping catheters, mapping systems. So what we're trying to do now really in modern ablation, the most typical approach is to try to build an electrical fence which will fence off the trouble inside the pulmonary veins and create a complete line of block. But of course we're doing that by actually putting in a series of point-by-point lesions with the catheter in order to try and build that fence. And if we leave a little gap in it at any point, then of course there's a chance for the electrical impulse to get back out. And if we have only stunned that area at the time, think we've blocked it, and actually a day or two later it recovers conduction, we're likely to have a failure of the procedure. So it's difficult to actually hold your catheter in that position for long enough to give a correct transmural lesion. As you know a lot better than most cardiac electrophysiologists, because they never normally see this, the heart is moving, twisting, it's a highly mobile structure, and we have to hold our catheter point absolutely still on each of these points, which has got to be contiguous and not leave those gaps if we're going to team up the 100 or so points that are going to isolate the 2 pairs of pulmonary veins. And they've got to stay in position for long enough to deliver enough energy to get a complete permanent transmural block without burning a hole in the heart at the time. I think it's important to not talk about atrial fibrillation as if it's all just one thing. We need to divide it up from the easiest to ablate types to the hardest to ablate, because I think that's particularly relevant if we're going to target where our combined efforts are going to be best directed. So I'm just going to show you now a series of the most relevant trial results to talk about what actually are the success rates that we see with catheter ablation. It was interesting when I was at the Navigating the Maze meeting, which Manuel did about a year ago, that it was, I think I came the day after Dr. Rugada had been presenting and telling everybody, all the surgical team, that the job was over, the electrophysiologists could do it all, there were no problems with any of the results. It's clearly not true, and I'll try and show you why. So if we start off at the easy end of the spectrum with paroxysmal atrial fibrillation, here are 2 papers from last year which are comparing the 2 commonest techniques, which is the point-by-point ablation we've just been talking about and the cryoballoon, where a balloon is forced into the mouth of the pulmonary veins. It's dropped down to a freeze temperature, which results in isolation of the muscle that's around the circumference of the balloon. And if we look at the 12-month success rate in terms of freedom from AF recurrence, with this technique we're talking 76%. With the cryoballoon we're talking around 73% at 18 months. And looking at UK data, which was published last year by Richard Schilling from Barts, where they have a particularly active program and they're doing large numbers of the cryoballoon procedures, they're looking at around 67% freedom from atrial fibrillation at 1 year. So I think these are the real results from the procedures as we see them in our own hands. And if you actually say, well, that's really talking about symptomatic, and if you put a 7-day loop recorder on as a snapshot to see whether you're saying it's a success, if you actually have a pacemaker or you have an implantable loop recorder in, then you're really looking at far lower results. This is from Steve Furness's trial. Steve is an extremely talented atrial fibrillation catheter ablator, but he's also extremely honest, and at 1 year the results using point-by-point or a novel multi-procedure, a multi-electrode ablation catheter was coming out equal in the two groups effectively at around a 54% success rate. And this is for the easy type, for the paroxysmal atrial fibrillation. This is our own experience with the cryoballoon, which I put up to show this was going back to 2010 when we first started using it. As I look at those patients now out to 1 to 5 years, only 57% of them have been completely free of AF. It's when you look at these short term, which is what most of the trials tend to report, is much shorter term data, that you see these better results of around about the 75%. And when you look at this group from Japan, which has followed up very meticulously its results using the point-by-point procedure, after a single procedure, out at 5 years, we're talking 59.4% success rate. So as there is this continual drop-off over time, it's not just all finished at 1 year. It is worth pointing out, however, that with a median of 1.3 procedures, so if about 30% of people get a second procedure, the success rate out of 5 years is pretty good for these easier to treat patients, 81%. So you have to balance up, well, maybe some of them are going to get 2 procedures, but we're actually talking about 2 procedures for an awful lot of our surgical approaches. So this is the intermediate group to treat the persistent AFs that haven't been going on for years, and this was published as one of the major publications in the New England Journal last year. And if you look at it carefully, freedom from any recurrence of a single procedure, only 49%. That's using all the different types of lesion sets that are most commonly used by most operators. And we've had our own data which has come out looking out to 24 months de novo procedures using some of these more novel techniques. Again, not fantastic. A drop-off as you follow them up, and 60% success off a single procedure out at 2 years. So there was a lot of excitement a couple of years ago over the idea that we'll map rotors and that we'll just go in and burn on 1 or 2 points where we've identified where the rotor is, and the initial results came out looking very good. But if you look at the later follow-up paper out at 890 days median follow-up, this is coming back down roughly the same. So this is doing the isolation of the veins and then doing rotors, 56%. So I'm really trying to just give the message that when you look hard at what's actually coming out of ablation data, it's not the 80%, which is being talked about in the best series by the best operators with multiple procedures, if you're just talking like a single trip to the catheter ablation lab. And this is really the area where I think there is so much to be offered by collaboration between surgeons and cardiologists. This is long-standing persistent atrial fibrillation, over a year of continuous atrial fibrillation. And when you look at this group, Karl-Heinz Cook's group in Hanover, he's looking at, from a single procedure at 5 years, only 20% freedom from atrial fibrillation. And from multiple procedures, which may be up to 1 to 5 procedures, getting to 45%. So this is a lot where really there isn't a good solution from catheter ablation at the moment. And in fact, if you look at the EP meetings, there's nearly always a talk now going up saying, long-standing persistent AF ablation, should we ablate it at all? Because of these sorts of results. Finally, just to finish off, there aren't that many studies which have looked at the same sort of lesion set as surgeons are trying to create, but trying to create it through catheter ablation. And what there is has been only really come out very recently. So in the last few months, there's been a paper from Brazil looking out to 16 months. in relatively short duration atrial fibrillation, 11 months, where they seem to be seeing very good follow-ups as far as they claim. David Keane from Ireland took a group which was 72% of persistent atrial fibrillation and found 75% free at 1 year, which is better when you actually box off the posterior wall, which of course is a novel idea for most catheter ablaters. So there may be mileage in trying to achieve this lesion set. The same thing has been replicated in study in Korea, where they actually looked at adding posterior wall or not having posterior wall in follow-up. And if you actually box off this posterior wall, there does seem to be a demonstrable improvement, as I suspect all of you as surgeons would have anticipated because of your knowledge of the Cox-Maze procedures, but it's news to most cardiac electrophysiologists. So the other thing that's crucial, as Malcolm said, is the complication rate. And this is probably where I think we have to be sensible, really, about the way in which we approach the mass of patients who need these sorts of procedures. This is the worldwide data looking at death, tamponade, stroke, which had an update paper giving a 4.5% serious complication rate and a death rate of 0.15 of catheter ablation. And that probably is the highest of the various series when you look at randomized trials in terms of major complications occurring. Of course, if you look at medical management, you look at just trying to treat these people with drugs, it's not safer. This data comes from John Cam, who on a meta-analysis, and I'm not quite sure I'll say exactly where this comes from, he quotes major complications from drug therapy follow-up at 30% and death of 2.8%. And if I look at my own procedural success rate, not procedural success rate, complication rate for 470 procedures, it comes up just below 1%. And that, I think, is relatively typical of most people who've been ablating for quite some time. We're not seeing, above 1% serious complication rates with stroke and death as a frequent phenomenon in the UK. And so you really have to be thinking about, for the people that you can treat with 1.3 procedures and see 80% out at 5 years, in other words, the paroxysmals, whether the complication rate for that is preferable with catheter ablation rather than surgery. So, just to conclude, around 100 AF catheter ablations per million population per annum. Around 55% of people with AF are under 75s, and at least 40% of them are remaining symptomatic. So about 2,200 per million population could benefit from AF ablation. We reckon around 75,000 of those on a UK-wide basis would be suitable for hybrid ablation at the moment. And the results, obviously, as I've shown, differ for the different types of ablation, whether you're talking single or multiple procedures, and you need to look at the difference between 1 year and 5 year results if you're trying to make sense of comparing different approaches. Thank you.